Hello, my name is Dr. John Preston. I'm with the Clinical Psychopharmacology program at Alliant International University in San Francisco. And in this brief video, I want to talk to you about an issue that I think has gotten a lot of media attention recently. If you look at our first graphic here, this is a picture of the cover of Newsweek magazine early in the year 2010. The title is Antidepressants Don't Work. And there was a very alarming article in there about the lack of efficacy of antidepressant medications. At about the same time, there was also an article in the Journal of the American Medical Association also pointing out the really significant problems with some of the antidepressant research and calling into question the efficacy of antidepressants. In order to really understand this, I think it's important first to lay a bit of groundwork by talking for a moment about effect sizes. So if we can have the next graphic, please. You can see on this slide, effect sizes are a statistic. It's a numerical way of showing the degree of superiority of a drug over placebo, or the separation between placebo and drug. Effect sizes of 0.3 and less are considered to be not clinically significant. When you get beyond this to 0.4 and beyond, now the drug is outperforming placebo and it does offer some clinical utility. The majority of medications, psychiatry, and the disorders that they treat, the effect sizes typically are somewhere between 0.4 and 0.6 or maybe 0.7. So across the board in psychiatry, the outcomes are not stellar, but they are very beneficial for many individuals. Looking at the next slide, though, this is really about publication bias, and this is just the truth. If you take a look at research studies that were done, these are called registration trials, are done by drug companies, submitted to FDA to get their antidepressants approved. You can see that those studies that had higher effect sizes tended to be the ones that got published in journals. And this has been the case for many, many, many years. Journals don't like publishing negative studies. The studies that did not have as good outcome, you can see together, if you average them together, had effect size of 0.31, didn't show up in the journals. And so when you read journals, then you're going to get a biased perspective on treatment outcomes. In the next slide, we'll see the four main types of treatment for depression that have some empirical support: antidepressants, that we'll talk more about in a few minutes, psychotherapy, particular kinds of psychotherapy, exercise, and for very severe and psychotic depressions, ECT or shock therapy can be effective. The next slide, at a glance, this looks at outcome data for psychotherapy specifically developed for treating major depression. And you can see each one of these is somewhat successful. For some individuals, it's absolutely a success. It's the treatment of choice, but it's not for everybody, and it doesn't bring everyone to remission. In the next slide, this is me and some of my buddies down at the beach exercising, trying to keep from being depressed. And there are impressive studies that show that regular exercise can treat even severe depression. Now, what's wrong with this picture? The problem is that when you have people enrolled in a research study, you can force them, basically compel them and force them to follow through with doing their exercises. And the data suggests that after a period of time, 15 to 20 weeks, that regular exercise can yield results that are just as effective as antidepressant medications. The problem is that in real life, it's very hard to get people who are clinically depressed to exercise and do it on a regular basis. Now let's take a look at drugs. Next slide, please. The biggest problem really with the newspaper, the Newsweek article, and the one in the Journal of the American Medical Association is that they were looking at one single drug versus placebo. And yet this is hardly ever done in clinical practice. If one drug doesn't work, you don't just give up at that point. You go to step two. And this brings up the whole issue of sequential treatments. The largest study done in psychiatry looking at medication treatments for major depression was the STAR-D program. This was sponsored by the National Institute of Mental Health. 4,100 patients, a very well done study. And what they did with these people who were very severely depressed. By the way, these are people who have not only severe depression, but also significant and complex comorbidity like anxiety disorders, comorbid personality disorders, substance abuse. Many of these people had medical problems that complicated the picture and so forth. So these were very, very seriously impaired individuals in the study. They started off by just using one drug. In this case, it was the SSRI Celexa. And they did aggressive dosing. Now, this was key to success in this. Aggressive dosing means to really use rather high doses if necessary. This oftentimes is not done in primary care settings, unfortunately, but if psychiatrists do this, they oftentimes can get much better results. Now, you'll see here that the remission rate, it took about 7 weeks of aggressive treatment to get people there. About 30% of people in the step 1 of the program reached full recovery. Now, if you look at the 30%, at first glance, it may not look like a very impressive outcome. However, keep in mind these are very, very severely depressed patients. Many of them, and the majority of them, had recurrent or chronic major depression. But then what happened was those people that did not reach full remission, then they went to phase 2, step 2. And here they were either changed to a different class of antidepressants that targeted different neurotransmitters, or they started having combination treatments where they're using 2 or sometimes 3 drugs together. Combination treatments are absolutely state-of-the-art in treating many medical conditions. If you look at cancer, hypertension, heart disease, AIDS, and so on and so forth, rarely would anybody ever just stop with one treatment if it wasn't effective. Trying alternative treatments or combinations of medications is really the way to go to optimize outcome. During the second stage, you can see that 55% of people reached full recovery. Those who didn't reach full recovery, those people who either responded not at all or they had partial responses, went on to step 3. And here you can see after they again changed to a different class of medication or added another medication on top of the antidepressant. Now we're up to 2/3 of the group of this 4,100 patients reaching full remission. And again, please keep in mind these are very severely depressed patients. Again, it certainly falls way short of 100%, but this is clearly 2/3 of people on an antidepressant alone reaching full recovery. Now, one of the problems with this is that it was medication alone, and in clinical practice, the most responsible thing to do is, in a sense, to really pull out all of the stops and to use combinations, not only medications, if that's indicated, but also psychotherapy, and then if you can get it, things like exercise, improving the quality of sleep, avoiding substances that disrupt sleep, like caffeine, getting rid of alcohol and other substances of abuse that can aggravate depression, a multimodal approach. Let's go to our last slide here. Be determined in achieving your goals. I think the best shot that we have to really help our patients recover from severe depression is not by looking at one single treatment, whether that's a single antidepressant or just one type of psychotherapy. I think the clinician who really knows what they're doing in terms of treating depression realizes that this multi-level assault on depression gives us really our best shot at helping our patients. The combination of drugs, psychotherapy, exercise, and so forth, as I mentioned before. The biggest problems that I see with both the Newsweek article and the one in the Journal of the American Medical Association are, number one, is that they were looking at these studies where exclusively looked at one drug versus placebo, which is not reflective of state-of-the-art treatment in psychiatry in the real world. But secondly, it has to do with a problem with the media. And when you have a front page article, a front cover article in Newsweek that says antidepressants don't work, but they have not carefully looked at sequential treatment, I think it's irresponsible. Consumers, our patients, they have a right to know about the limitations of treatment. We need to be honest with them about side effects from medications and the limits of medication treatment. At the same time, an article that says antidepressants don't work without really exploring this in more detail, in my opinion, is irresponsible, because there are many people out there who struggled for years with depression. They probably thought about treatment, but they're reluctant, they're afraid, or the negative stigma of getting mental health treatment. Any number of reasons that people don't get treatment. Half the people in the United States that have major depression never get treatment. They grit their teeth, they suffer tremendously. And when the media comes out with this kind of an article that, in my opinion, is not balanced, then I think it does a disservice to many of these people that are out there suffering. Okay, thank you for listening.